afternoon and welcome to the Tilman J. Fertitta Family College of Medicine Grand Rounds. It is my pleasure and honor to introduce today's speaker, who has already warned me that I am not to read his bio sketch. He says I can introduce him as a country doc. I would prefer to introduce him as a gentleman scholar, the man who opened a medical school in the middle of COVID and who graduated his first class of medical students last Saturday. And the reason I and many others left other established positions to join him on this venture to open this school. So Dr. Stephen Spann.
All right, well, good afternoon. It's good to have the opportunity to chat together. I tried to pick a title that would be a little bit controversial and provoking. And you may be thinking, well, what's this about the science of the art of medicine, right? We talk about the science of medicine, we talk about the art of medicine, but what's this about the science of the art of medicine? My goal, my hope is that at the end of our time together, you will come to understand that there is a science behind the art of medicine. This is our disclosure. I have no conflicts of interest that I know of. And in fact, I'm going to be talking about a number of core concepts, principles that we all are familiar with that have guided my practice of medicine and teaching of medicine for a number of years. And I think it's sometimes useful to review those and to think about how we use them in our own practices and about how we teach them to our learners. These are the several learning objectives that I put together. This quote is from a paper that was published in the Medical Teacher a few years ago by a medical student, really talking about the tension, if you will, within our medical education system between the science of medicine and the art of medicine. He says that he came to medical school with a great compassion for patients that were struggling or suffering with the disease. But after a couple of years, it seems to him that the pressure to master the science has trumped his desire to master the art of medicine and to see patients as more than their disease, to meaningfully connect with them and comfort them. You know, that is a shame, right? That to feel that the science trumps the other. And he apparently participated in this invitational conference about the USMLE scoring and felt that was interesting. But he notes here that the question remains as to how a training environment will be created that encourages valuing humanity to the same degree to which we currently value scientific knowledge. And he expresses his concerns that the current training environment promotes a belief among medical students, including himself, that the art of medicine is less important and less valuable because it can't be tested. Now, I think there probably are ways that we can test the art of medicine as well as the science, if you will. And he quotes this well-known statement by William Osler, who was the first chair of medicine at Hopkins, who basically said that the good physician treats the disease, but the great physician treats the patient who has the disease. So what is this about the art of medicine? And I think it's hard to find the definition in a dictionary. I think these are my thoughts that I put together over the years. I think the art of medicine really is expertise that we gain through observing experience in our practice. We talk about practicing medicine, and I think it's because we are continually learning and gaining expertise across our careers. It really has to do with the relational aspect of what we do, our relationship with our patients, with our colleagues. And it's all about understanding illness, understanding people, and understanding context. Now, today we try to teach evidence-based medicine. We really emphasize that in our curriculum and in our practice. And I think it's useful to go back to the original writings of Sackett and colleagues about evidence-based medicine. Here's how they defined it as the conscientious, explicit, and judicious, underline judicious, use of current best scientific evidence in making decisions about the care of individual patients. And notice that they say that this integrates clinical expertise, our clinical expertise, with the best scientific external clinical evidence from systematic research. So it really is an integration of the art, if you will, the clinical expertise with the science. And here's how they describe clinical expertise. It's the proficiency and judgment that we acquire through our clinical experience and clinical practice. This is not something we learn out of a book or out of a scientific paper. And they say that it's reflected in our diagnoses, and I would argue treatment being more effective and efficient as we identify and compassionately use the individual predicament in our decision making. And we understand and utilize their rights and preferences as we make decisions about their care. Now, one of my academic interests over the years has been medical decision making. And early in my studies of this part of science, I read this book by Elstein and colleagues, where they did a fair amount of research. They observed physicians making clinical decisions, and they sort of derived this model of medical decision making, and it's called the hypothetical deductive model. And contrary to the way we first teach medical students to take a complete history and do a complete physical and then order a bunch of diagnostic tests and sort of wait for the diagnosis to fall out in an inductive reasoning model, they found that that's not the way we solve clinical problems and make clinical decisions, that we start with cues, which may be verbal cues, they may be visual cues, they may actually be olfactory cues, they may be symptoms, they may be signs that we observe. And very early in the clinical encounter, we start to generate diagnostic hypotheses. It may be based on the reason for visit. Epigastric pain. I start thinking about, oh, gastritis, peptic ulcer disease, gallstones, et cetera, et cetera. And that from those initial hypotheses, we do a very systematic search where we gather more cues, we take more history, we do a physical exam, maybe we order diagnostic tests, and that is an iterative, circular process, if you will. Sometimes unexpected cues come into play. At the end of the day, we have to make a decision. We may not always have diagnostic certainty. In fact, seldom do we have diagnostic certainty, but we have to do something to take care of the patient. And sometimes we use time and follow-up to see if, in fact, they're responding to our management. We may have to revise our diagnosis, revise our treatment, but it is a very circular process, if you will. Now, I mentioned that we seldom, if ever, have absolute certainty about our diagnosis, and I'm fond of asking medical students to name a diagnosis which we're 100% sure of. And usually they say, how about death? You know, death, that's 100% certain. Well, how about the patients who get diagnosed as dead, sent to the morgue, and wake up? And all of us are familiar with those situations. I think a quite certain diagnosis is a compound fracture when the patient has a broken bone and it's sticking out. That's pretty certain. But the fact is that most of the time we are uncertain. And so there is a probability estimate of disease that oscillates between 0, which means absolutely sure that that disease is not present, versus 1 or 100% where we're absolutely sure that it is present. But very seldom, if ever, do we have a probability of 0 or 1. It's usually somewhere in between. And what we hope, in fact, is that when we do a diagnostic test, the result of that test would give us absolute certainty of disease or absolute certainty that that disease is not present. But again, our tests are not perfect. And as we all know, sometimes a positive test can be a false positive, and a negative test can be a false negative. In the ideal world, a disease patient would always have a positive test, and a patient who does not have the disease would always have a negative test, but that's not reality. And so we define 4 different mathematical relationships. One is called sensitivity, and that's the probability that a patient with the disease has a positive test. And specificity is the probability that a patient without the disease will have a negative test. More interesting to the clinician is, okay, so if my patient has a positive test, what's the probability that they have the disease? We call that predictive value positive. Or if my patient has a negative test, how sure am I that they don't have the disease? And we call that predictive value negative. And these are related through something called Bayes' theorem. And I'm not going to go into that today. But let me just show you the results of Bayes' theorem. So if you pick a test, a pretty good test, in this case, a test that's 90% sensitive and 90% specific, what you can see here is that the predictive value positive and the predictive value negative of the test are related to the probability of disease in the patient. We call that the pretest probability. How probable do we think it is before we do the test? And so if you think that there's 0 probability of disease and you get a negative test, then you're absolutely certain that the patient does not have the disease. And conversely, if you think that there is 100% probability that the patient is diseased, then a positive test you can trust 100%. But the key here is that there is a relationship between pretest probability of disease and the predictive value of the test. So the higher the pretest probability, the higher the positive predictive value, and the lower the negative predictive value of a test. So that's a little bit about Bayes' theorem. Now, how does this work in practice? Let's take a very common problem that we see in primary care, and that is a young woman who comes in with burning on urination, urgency, and frequency for 3 days. These are symptoms that are fairly classic for a lower urinary tract infection. And usually the test that we would be tempted to do is a urinalysis where we look for white blood cells in the urine. And we know from studies that the sensitivity of the white blood cells present for urinary tract infection is 80%, and the specificity is 95%. And if you do the calculations, you can see what the predictive value positive and predictive value negative would be if you know what the baseline probability is. And so the epidemiologic studies, in fact, showed that the baseline probability of urinary tract infection with these symptoms is 80%. Well, it turns out that if you do the urinalysis and you see pus cells, you see white blood cells, that takes your post-test probability to 98%. Well, that's pretty good, right? But if you don't see white blood cells, the probability that the patient does not have the disease is only 54%, meaning that there's 46% probability that she still has the urinary tract infection. Now, would you tell her you don't need an antibiotic if there's 46% chance that she is in fact infected? Well, I think most experts would say no, you would go ahead and treat her. But in fact, current clinical guidelines would suggest that a very solid approach in this situation would simply be to treat her and not do the urinalysis, because the test doesn't give you that much certainty. So this is just an example of how the pretest probability of disease affects the way we interpret the data of the test. Now, how do we guesstimate pretest probability of disease? Well, ideally, there have been studies done, as the one I just showed you, right? Epidemiological studies that will tell you what the pretest probability of disease is given a set of symptoms and signs. We don't always have that. We use patient risk factors. For example, if a young woman comes to the emergency room with sharp stabbing chest pain and she's 25 and has no risk factors for coronary disease, you know that her pretest probability of having a heart attack is way, way low. We use history and physical data that we obtain, but we also use patient context. And patient context is actually a very important component of estimating the probability of disease. Now, one of my favorite authors in family medicine and the principles of practicing primary care is Dr. Ian McQuinney, his classic textbook of family medicine. And he writes about the cues that help us understand that the context may have to do with personal and interpersonal issues, that it may not be organic disease. It may be more of a psychosocial problem. And McQuinney points to these cues. He says sometimes patients come in frequently with minor illnesses, or they come in with the same symptoms or multiple complaints, or they come in with a symptom that's been there a long time. Why are you coming in now? Or they have a chronic disease which appears stable, but they come in for an acute visit. Well, you know, what's really going on with the patient? Sometimes there's incongruity between their distress and the comparatively minor nature of symptoms. Sometimes there's a failure to recovery from their illness or injury. There may be secondary gain going. Sometimes you just can't reassure them. Sometimes parents bring in children with minor problems. Sometimes an adult brings a relative with them. Sometimes the presenting symptom complex just doesn't make sense. And these are all cues that suggest that there's a personal and interpersonal context. I was remembering a 10-year-old boy that I saw in Cordoba, Argentina, many years ago when I was there visiting a family medicine residency program as a visiting professor. And so they decided to bring their most challenging patient in for the visiting professor to see. This little boy came in with his mom, and the story was that he was constantly having asthma attacks, despite the fact that they were treating him with the best available medications for asthma at the time. So recurrent symptoms, time after time, not responding to usual medical therapy. I started taking a history, trying to understand what was going on. And I discovered that there was a problem in the family, dysfunctional family, where the father was alcoholic and he would come home inebriated, drunk, and physically abuse his wife. The child observed that, and that triggered an acute asthma attack. So it was the repeated presentation of the symptoms time after time that didn't get better that led me to investigate what was going on in the family environment that ultimately helped me to understand the real genesis of the problem, if you will. Another one of my favorite authors is Arthur Kleinman. He's a psychiatrist, medical anthropologist who spent many years at Harvard. I think he's professor emeritus, but still teaches there. And I had the privilege of presenting at a conference where he was also presenting, got to know him personally. He's just an amazing guy. And he wrote a paper back in the late 70s titled Culture, Illness, and Care, Clinical Lessons from Anthropologic and Cross-Cultural Research. And Kleinman makes a useful distinction between disease and illness. And he talks about the fact that we typically diagnose and treat diseases, and we view those as structural abnormalities in body function, in organs and systems, but that patients really suffer from illness, and that's their experience of being sick. So he says there's a difference between sickness and illness. And in the Western paradigm, we are trained to view disease, if you will, as really a maladaptation of biological and psychophysiological processes. But illness really represents the personal, interpersonal, and cultural reactions to disease or discomfort. And clearly, illness behavior is strongly influenced by culture. As I have worked and practiced around the world, I see a number of different illness behaviors in response to the same sickness influenced by cultures. He also makes a distinction between healing and curing. And he notes that traditional healing in the developing world and popular healthcare in our own culture is mostly concerned about illness, with treating the experience of illness. And he notes that healers really seek to find a meaningful explanation to illness and to respond to the personal, family, and community issues surrounding that. Whereas in biomedicine, we're historically and typically more focused on recognizing and treating and ultimately curing disease. But Kleinman points out that we should be doing both. We can't always cure, but we can often heal and we can often care. And Kleinman says that there shouldn't be a dichotomy, that we should be able to be both healers and sometimes curers. It's not often that we get to cure. Now, let me remind us of the WHO definition of health, which goes all the way back to the founding of the WHO, the World Health Organization, in 1946. You're familiar with this. It's the state of complete physical, mental, and social well-being, and many of us would add spiritual well-being to that, and not merely the absence of disease or infirmity. So if healing is restoring folks to health, it's restoring them to well-being. That's not necessarily curing them, but it is helping them to regain well-being. Now, Tilman talks about these different structural domains of healthcare. You can see them listed here. He differentiates between our domain, which is professional, a more popular domain, a folk domain, which is typically non-professional healers. And in some cultures, those are the predominant healers. And he notes that each domain has its own way of explaining things, its own social roles and interactions and institutions. And he notes that in most of the world, the majority of healthcare takes place in the popular domain. Well, my good friend and colleague, Dr. Larry Green from the University of Colorado in 2001, published this paper, which was a revisit of a very well-known paper about 40 years prior by Dr. Carr White at Johns Hopkins School of Public Health. That paper was called The Ecology of Medical Care. And both of these papers examined what happens to 1,000 adults living in the population during 1 month and their experience around health and illness. And the findings were fairly simple. There hadn't been a lot of changes between the two papers, which are 40 years apart. But Larry Green found that if you follow 1,000 adults over a month, that some 800 of them will have some sort of a symptom. However, only 327 consider seeking medical care. 217 actually visit a physician's office. 113 of those go to primary care, about half of them. 65% seek care from a complementary or alternative medical provider. 21% may go to a hospital outpatient clinic. 14%, not percent, but 14 out of 1,000 get home health care. 13 go to emergency department, 8 are hospitalized, and less than 1 per 1,000 ends up in an academic medical center. Now, the bad news is that most of us trained in academic medical centers, right? So we earned medicine in a very select, biased sort of setting. But this, I think, reveals that most symptomatic illness is cared for in a more popular setting. Now, Tilman points out that the interactions and transactions we have between patients and clinicians are interactions and transactions between explanatory models. And they're often differences of opinion, discrepancies in content and values, expectations, and goals. What he says is that patients come to us as healthcare providers with an explanatory model of what's going on. And we have our own sort of medically oriented explanatory model. And that if we don't get the two to somehow mesh or synchronize, there will not be healing, or it will be difficult for healing to take place. Let me give you a classic example. So most patients who come to a physician with a headache are worried that they have a brain tumor. And so if you don't address that, if you don't take a good history, do a good exam, and then have a discussion with them about the CT of the brain that they come expecting to get, you're not going to help them. You're not going to heal them. And Tilman points out that the patient model often is parallel to the physician model. He says they care about etiology, what causes symptoms, the pathophysiology, what's going to happen with the course of illness and the treatment. And that we need to understand that model. We need to elicit that model, which includes their beliefs about the illness, how they interpret the personal and social meaning of that disorder, what their expectations are for what will happen, what we will do, and their treatment or therapeutic goals. And that when we understand their model and can compare that to our model, we can figure out what the discrepancies are that may cause problems in clinical management. We can somehow make our model clearer to them, if that's important, and even clarify conflicts that are often not related to different knowledge, but really to different cultural values. And so here are the questions that Tilman suggests that we use to understand a patient's explanatory model. What do you think caused the problem? Why did it start when it did? What is it doing to you? How does it work? How severe is it? Will it be short or long? What kind of treatment do you think that you need and should receive? A couple of years ago, I was seeing a Hispanic patient who had diabetes, and this patient came in with pain in the foot, in the bottom of the foot, in the heel of the foot, worse in the morning when he got up and walked around, gradually got better. And I knew that he likely had something called plantar fasciitis, which is an inflammation of the deep fascial tissues of the foot, the bottom of the foot, usually in the heel. Very common and very straightforward to treat. But in talking to the patient about his explanatory model, he told me that he thought there was something badly inflamed inside his foot, that he had had this before and he had gone to a physician and had received a shot of corticosteroids, and that had made it better. Well, that's sort of one of the last results in my therapeutic armamentarium. And I really didn't want to give him a shot of corticosteroids because he had his diabetes and that would make it worse. And we usually treat it with heel pads and stretching exercise of the Achilles tendon, ice massages. And if that doesn't make it go away, we can put them on a night splint to sleep in that keeps the ankle in slight extension. And so I explained this to him, and we talked about his explanatory model and mine, and what he wanted and what I was proposing. And we came to agreement. He said, okay, well, I'll try that. You know, I don't want my diabetes to get worse. So we were able to mesh our models. So what is it that the patient really wants? What are their goals? What are the problems that this illness has caused? What do they most fear? Those are important aspects of information we can gain. So again, we explain our model, we compare the two models, and hopefully we can find some synchrony. We can attempt to educate the patient. Sometimes we need to mediate between those two different orientations. And when that happens, it's likely that the patient will adhere to our treatment and that healing will take place. I want to shift now and talk a little bit about our role as healers. And I'm going back to McQuinney, and this is a picture taken several years ago in rural Honduras. We were on a medical mission there, and this little lady lived in an adobe hut with straw roof. She was toward the end of her life. And I was there just trying to help her gain comfort. But McQuinney talks about several aspects of our role as healers. One is that we need to understand that healing sometimes takes time. And I'm fond of calling this tincture of time. And sometimes I use that word with patients. We use therapeutic agents of physical healing, but we also use our relationship. We listen, we have empathy and compassion, we reassure, we recognize suffering. We try to understand the meaning of that illness to the patient. We try to be present, as is noticed in this classic painting by Sir Luke Fields called A Doctor from 1874 in Britain. Remember that at that time there were no antibiotics, there weren't a lot of therapeutic agents, and a lot of times all the physician had to offer was himself. for herself is presence. Importance of giving hope, realistic hope for survival, for future events, for spiritual realization, for the present moment. And then helping patients to find their way through the ordeal to a new wholeness. So this is our role as healers. There's been a growing evidence base around the importance of compassion and empathic relationships in the healing process. Many of you are familiar with this book. We gave it to each member of the first two classes of our medical school. And this is an evidence-based review of the evidence, scientific evidence, of the importance of empathy and healing of empathy and compassion in the healing process. And the authors, Serziak and Mazzarelli, differentiate between empathy and compassion. Empathy is feeling with. Compassion is an emotional response that triggers action to relieve suffering. Now, in this survey of physicians and patients, most of the patients and physicians agreed that compassion was very important to successful medical treatment. But only 54% of patients, but 78% of physicians thought that most health professionals provide compassionate care. Interesting that the doctors overestimated that compared to the patients. We know from a number of studies that medical students arrive at medical school with empathy and compassion, but somehow, for some reason, that declines over time, not just throughout their medical school, but throughout their residency. And the likely reasons include that there's a hidden curriculum. We all know about that. And even the informal and the formal curricula somehow contribute to that. I think we're all aware of the fact that health professional burnout has increased in recent years and is having a major negative impact on our healthcare professions. And Maslach defined that as an erosion of the soul caused by deterioration in our values, dignity, and spirits. There are three components, as you can see here: emotional exhaustion, loss of passion for our work, depersonalization, where we begin to treat patients less as human beings and more as objects, and then a sense that our work is no longer meaningful or purposeful. And studies have shown that that has been increasing. You can see this classic study from Schoenfeld that showed an increase in physician burnout from 45% in 2011 to 54% in 2014, decrease in physician satisfaction. And interestingly, burnout in U.S. physicians is way higher than burnout in our general population. And there are certain specialties that are more at risk, those frontline specialties such as emergency medicine, internal medicine, family medicine, and neurology. A more recent survey, 2023, compared burnout pre-COVID and post-COVID, and the pre-COVID survey had showed that it was around 42%. Post-COVID showed it had increased 53%, and notice that the rate of physician depression, reported depression, had increased as well. So burnout is a substantial problem in our profession. A lot of causes, potential causes, of course, the increased push to see more patients per unit time, what many of us call the hamster treadmill of practice. More emails in our lives from patients and non-patients. The use of electronic health records. Now, I was an early adopter. I installed the first electronic health record at UTMB in '94, the first one at Baylor in '99. So I'm not anti-EHR, but the evidence suggests, as we will see, that electronic health records have contributed significantly to burnout. The increased performance metrics, not just volume of patients, but also quality, and then the shrinking autonomy of physicians, particularly as more and more physicians are employed by hospitals and for-profit companies. And it just seems like we spend less time with our patients and more time with our computers. And this is a picture drawn by a 7-year-old little girl and given to her pediatrician, who is actually a senior pediatrics resident at one of the best pediatric residencies in our country. And you can see here the little girl and her mom and perhaps aunt or some other family member that are sitting over here on the exam table, around the exam table, and the pediatrician back in the corner working on the EHR. Pediatric resident said when he saw this, he thought, oh my goodness, what am I doing? This study from Hopkins, done a number of years ago, looked at interns and the way they spent their time. And you see here that only 12% was spent in direct patient care. 40% of their time was spent at a computer. And this paper by Sinski looked at practicing outpatient physicians in 4 specialties: family medicine, internal medicine, cardiology, and orthopedics, and found that they spent only about 27% of their total office daytime in direct clinical face time with patients, 49% doing HR and desk work. Of the time they spent in the examining room, only 53% of that time was spent in direct clinical face time with their patients. And regretfully, they were spending 1 to 2 hours at night after clinic time was over, finishing their EHRs. So look at these 2 pictures. Look at the difference. I'm concerned that healthcare is becoming less relational, more transactional. You've been to see a physician lately or get a diagnostic test, you get to the front desk and the personnel are there typing into the computer, ticking all the boxes. Often they don't even look at you. And many times a physician, as opposed to interacting with a patient, is interacting with the electronic health record. Now, this book that I've mentioned by Traziak and Mazzarelli shows that there is an abundance of evidence that we have compassionate, empathic relationships with our patients, that the outcomes improve. And I'm not going to go through all of this. Some of it relates to the fact that just being present decreases loneliness, and loneliness is an important risk factor for illness and disease and even death. Your interactions, or the quality of your interactions with the anesthesiologist pre-op, predicts how much post-op pain and medication you will require. And people who've gone through trauma have found that when their healthcare team is compassionate, that promotes healing. And there's evidence that in palliative care, compassionate relationships improve not only the quality of life, but the length of survival of the patients. Compassion affects perception of pain. There are studies in diabetic patients that show that when the relationship between the healthcare provider and the patient are compassionate, that the outcomes of glycemic control are better. Patients are more adherent to our prescriptions and recommendations. When we are taking care of patients who are depressed or anxious or distressed psychologically, those compassionate interactions are healing. They help patients be more self-efficacious. They help restore hope. They help us understand our patients' purposes in life and their values and meaning, lower the risk of medical errors, improve communication. There's also evidence that compassionate, empathic relationships lower the costs of care. And let me remind you that the definition of value in healthcare is a relationship between quality and cost. So compassionate relationships increase the quality and decrease the cost. They increase the value of the care we deliver. So when those relationships exist, when we listen to our patients, when we pay attention to them, the number of diagnostic tests decrease, the number of specialty referrals go down, patient adherence goes up. We've known for years that good relationships lower the risk of malpractice. And for patients who are high utilizers, those relationships help reduce high utilization. We talked about burnout. There is substantial evidence that when healthcare professionals enjoy empathic, compassionate relationships with their patients, that the risk of burnout goes down. The higher the empathy, the lower the burnout. And Terziak and Mazzarelli, in summarizing the data, say that there's a preponderance of data that our human connection with our patients can transform the experience, not just for the patients, but for us as caregivers, and trigger a positive emotional response, joy in building relationships. During the time that I was in the United Arab Emirates, I was attending on the inpatient internal medicine residency service, and we admitted a Jordanian woman who was living in the United Arab Emirates with a severe attack of asthma. She was hospitalized. We put her on all of the usual aggressive treatments we use to break an attack of asthma. And days were going by and she was not improving. And we would see her every day. I would examine her. And finally, we really began to get to know her and to try to understand her life situation. And we learned that her husband had recently divorced her, had taken all of their belongings, had essentially left her destitute, and her children were not providing her any support. And she was undergoing a huge amount of stress. And I knew from experience and training that when asthmatic patients are stressed, they get sick, and they have trouble recovering. So we devised a plan to involve social work and to get her some emotional support. And we began to spend more time at bedside with her, talking to her, being compassionate with her. And she slowly began to improve. And toward the end of her hospitalization, she had pretty well cleared. Spent some time talking with her about discharge plans. And as we were leaving the room, she said, "Doctors, every time you come by to see me, I feel better." So we stepped out into the hall with the residents and I said, "What do you think that means? Do you think it means that part of our healing is related to our relationship with her? How does that make you feel?" And we talked about the joy that we can experience from those healing relationships with our patients. And during my time there, I began to pay attention to those moments of joy in my day and to celebrate those moments of joy. So in wrapping this up, I want to just summarize what we've talked about. We've talked about the fact that there is an art to medicine and there is a science, but I hope that I have convinced you that there is a science that explains the art. And the science says that the art is important. We've talked about the difference between disease, and illness. We talked about the explanatory model and the importance of trying to get those to mesh so that we can be therapeutic. We talked about different aspects of healing. And we talked about the importance of compassionate, empathic relationships in healing. We talked about burnout, and we talked about the evidence that when we, in fact, enjoy those compassionate, empathic relationships with our patients and experience them becoming better, being healed, that is a source of joy. So I think that we can use this in our own practice. Every time I am seeing patients, before I walk in the room, I make a mental note that the relational aspect of the visit is absolutely key to their healing. And I think we can teach these principles to our students and our residents so that they can become experts in the art of medicine. I'm going to stop there. Thank you very much. I'll be happy to take any questions that the audience might have. Any questions, feedback, disagreements?
Dr. Spann,
Yes.
wonderful presentation. Thank you very much for illustrating us about the art and the science combination. So the question is mostly related to the current academic model. So you know what the forecast is, and then you have the experience. You are the captain of this ship. So how do you see the model currently evolve, or what we should do actually to ensure that this aspect of compassion becomes center through which the school gravitates, another system that is what apparently is driving us right now through?
Well, we tried to build these concepts into our curriculum. We've had a significant emphasis on patient-centered care, relationship-centered care. Of course, we have tried to teach about social determinants of health, which are a major component of the context. We try to teach our students to take good histories and do careful physical exams. We're trying to teach them about evidence-based medicine, the whole issue of probability of disease and the way it affects interpretation of tests. And I hope that they will eventually learn that context is absolutely critical to that assessment. It's challenging because I think students struggle to learn the science, and so they see this stuff as less important. As we saw from the quote from the student who wrote the article, they don't feel like they're tested on that. They're tested on the blood and guts and molecular basis of medicine and not so much on the art. But I think that there is beginning to be more inclusion of those concepts in the testing. I will tell you that many healthcare organizations around the country are adopting this as a major part of their mission and vision and strategy. I think there's a growing emphasis on compassionate relationships in healthcare. University of California, San Diego received a $100 million gift to establish a center to study the importance of compassionate medicine in healthcare. So, you know, I think there is more and more awareness of the importance of this. Certainly there's an emphasis on value-based care, high-value care, and I think the evidence is substantial that this kind of care increases quality, it reduces costs, and increases value. So I am hopeful, guardedly optimistic, that this will become more and more important. I think more and more medical schools are including it in their curriculum. And so I'm hopeful that we're going to see more of this in our medical school curriculum. Other questions or questions from people online? All right, anything else? Well, thank you for being here. Hope you have a great day.
Thank you.